class, we have dealt with neurodynamic and systems involved in neurodynamic. Today, we'll be dealing with assessment of mechanical interface, diagnostic neurodynamic, levels of neurodynamic examination, and types of dysfunction. Coming to mechanical interface dysfunction. Talking general mechanical interface dysfunction, the symptoms are different compared to others. Let's look into what it is. When we are dealing with general mechanical interface dysfunction, there is X and more prominent compared to your dysesthetic symptom. Second point is it occurs in distribution related to your musculoskeletal structure. It may or may not involve your neural structure. Coming to the third point, provoked by opening or closing manures. Last video we have already dealt what is opening and closing manure. You can go back to the video and check it. So, general mechanical interface dysfunction provoked by opening or closing manure. Last point, inflammatory or degenerative component is very common in general mechanical interface dysfunction. Let's look into physical examination, what it includes. First point, interface finding more prominent than your neural finding, which includes, that is nothing but interface finding. The structure finding is more prominent than neural finding. Let's look into what it includes. It includes soft tissue palpation for your trigger point, spasm, tightness, cuts, wounds and scars which are already visible, fibrosis which is a muscular or tendon dysfunction, and muscle tightness. This can also be identified in interface finding. Neurodynamic tests often reveal covert abnormal finding. Covert is nothing but hidden or surprise. Please remember this word. Now, neurodynamic tests often reveal covert abnormal finding, which includes ULTT for radian, median, and ulnar nerve, LLTT for all the lower limb nerves. Now, this diagram is given in the Neurodynamic book by Shacklock. Let's look into what is this diagram. This is your diagnostic neurodynamic. Now, when a patient is coming to you for pain, first diagnose whether the pain is origin of the pain. Let it be your musculoskeletal or let it be your neurological. Coming into the diagram, look at the diagram. Symptoms with structural differentiation. When the patient is coming, you need to diagnose where is the pain, musculoskeletal or neurological. If there is no changes in musculoskeletal, write down. Definitely there will be change in neurological. Now coming to change in neurological, let the change be normal or abnormal. Write down what it is. Write down what is the change, normal or abnormal. Now if abnormal, write down covert or overt response. Let's look into what is covert and overt in the further slides. This is how you do diagnostic neurodynamic. Now briefing this procedure out. Subject, when the complaint is pain, when a patient is arriving with a pain complaint, second point, make sure whether to check whether it is neurological or musculoskeletal origin. Once checked, do structural differentiation to assess in detail both the system, that is your musculoskeletal system and your neurological system. After assessment, if you get to know that it is your neurological system, do the neurodynamic test, that is the sensitivity test, that is your ULTT and LLTT, to check whether the reaction towards the test is normal or abnormal. Now, if the reaction is abnormal, then check for covert or overt. This is the procedure to follow when your diagnostic neurodynamic is in the picture. When you are diagnosing the patient using neurodynamic principle, this is how you have to follow. This is the procedure for that. Now coming to since when we are discussing what is covert, overt. Let's look into it. What is overt and covert? Let's look into the picture. Under covert, she is hiding her face. She is covering her face. There's something secretive going on in her eyes. That is your covert. And overt is nothing but true. So thinking about this, if the pain is hidden, pain is secretive, that is your covert pain. If you cannot diagnose easily, that is your covert pain. Overt pain, it is open, it is visible, it is easily diagnosable. That is nothing but your overt pain. Let's look into it into depth. Covert, as I already told, it is hidden pain. Second point, it has varying symptoms. That means it can be pins and needles sometimes, it can be numbness sometimes, it can be tingling sometimes, it can be diffuse pain sometimes. You cannot identify. It can be radiating pain sometimes, it can be localized pain sometimes. So it has varying symptoms, hence it is very difficult to diagnose. Third point, pain present throughout the day and night. or sudden appearance of pain occurring any time during any moment. As I already told, patient cannot complain that only at night time my shoulder joint is paining, only at night time my neck is paining. No, he will complain in fact that the pain is not easily diagnosable. It can pain at any time. It can pain a day, it can pain at night, early in the morning, bedtime, 3 o'clock in the night, or doing some particular, not particular, doing any movement of the neck. Sometimes it pains in extension, sometimes it pains in flexion, sometimes it pains in right side flexion, sometimes it pains in left side rotation. So it cannot be easily diagnosed. Coming to the fourth point, diffuse pain or irrelevant to the structure affected. Though the structure affected is MSK, that is your musculoskeletal structure, pain might be radiating, that is your neurological pain. So it is very difficult to diagnose. That is nothing but your covert pain. Best example is piriformis syndrome. Piriformis muscle is tight, which leads to impingement of the sciatic nerve passing between the heads of the piriformis. Once the piriformis is tight, it will definitely cause impingement of the nerve. Hence, the patient is complaining of radiating pain in the leg. But if you diagnose it as neurological, you will treat for neurodynamic. But the pain is again going to occur back to the patient. Hence, you have to reduce the musculoskeletal structure, that is your piriformis tightness, to relieve the pain which is seen in the patient. If you use only neurodynamic for that patient, the pain is going to occur back again. This is the best example for your covert. Looking into overt. As I already told, overt is true. Overt is open. You can see. You can easily diagnose. Let's look into what it is. Overt, blatant or out in open. That is, it is true and open. Perfect symptoms regarding the structure affected. If MSK is affected, symptoms only restricted to MSK. That is diffuse pain, trigger point pain, spasm pain, tightness pain, contracture pain. These are all your MSK. So it is only those, not your radiating pain. Radiating pain is going to come in neurological. So symptoms are relevant. Only those symptoms are seen according to which structure is affected. That is your overt. Coming to third point, on pain only during certain activities. Only during my lifting overhead shoulder activity. Only that time it is paining. So my shoulder joint is affected. Not during when my hand is at the rest. When I'm stretching a policeman's tip hand, which is a particular example and a neurodynamic test and mobilization for radial nerve, during only doing that it is paining. Then it is only for radial nerve. It cannot be for ulnar nerve. So that is your overt pain. Coming to fourth point, localized pain or relevant to the structure affected. Basically, I just now told you that if musculoskeletal structure is affected, only those symptoms are seen, only that part is affected. If your neurological is affected, only those symptoms are seen, only that part is affected. That is your overt pain. Coming to levels of neurodynamic examination. This is very important. There are 4 levels, 0, 1, 2, 3, and third level is divided into 3A, 3B, 3C, 3D. Let's look into what it is. This is the diagram taken from Neurodynamic book by Shacklock. Levels 0, contraindicated. As the name only suggests, the patient is contraindicated. Here, contraindicated is not only for your neurodynamic assessment. Contraindicated is also for your neurodynamic therapy. That is your neurodynamic flossing. Coming to level 1, that is limited. As the name only suggests, the patient is very limited. Sometimes you can do the neurodynamic test. You can also approach neurodynamic flossing to the patient, but in a very limited way. That is nothing but your level 1. Level 2, standard. Standard neurodynamic test as well as therapy can be performed on such subjects. Coming to level 3. In that level 3A, neurodynamically sensitized. The best example is when a patient is coming to you. You perform SLR test for sciatica. When the symptoms is high in nature, then only mark this test. That is, the patient is neurodynamically sensitized. It is abnormal. That is nothing but your level 3A, neurodynamically sensitized. Coming to level 3B, that is your neurodynamic sequencing, which is the universal law of the neurodynamics given by both Butler and Shacklock. We have already dealt with this in the previous video. Let's look into it, what it is. Let's just remember that. Sequencing, that is, all the joints should be sequenced. When you're doing the test, activate all the joint, stretch the nerve at every joint so that there is increased neural tension within the nerve because of the stretching applied at every joint. Same thing is in 3B level neurodynamic sequencing. Following sequence wise is painful, such as that addition of sequential components stretches the nerve at every point, suggesting the increased tension in the nerve. Point of painful is held on further adding the sequential joints will aggravate the pain. The last point suggests that when my ulnar nerve is more painful at elbow, on testing I will definitely find there is some pathology at the elbow. On addition of forearm, wrist and fingers, it is going to further aggravate the symptom of ulnar nerve. That is nothing but your level 3B neurodynamic sequencing. Coming to level 3C multistructural, it is again the same. Multiple joints are added so that the nerve gets stretched at every single joint. 3D level 3D symptomatic position or movement. Particular movement or position producing pain is chosen for the therapy. For example, best example, policeman's tip hand is for radial nerve ULTT. If that is only painful, then do choose the same thing for therapy. Not by abducting the shoulder, flexing the elbow, rotating the forearm and then touching the scapulae and then doing side flexion, which is the best example for your ulnar neurodynamic test, and flossing. If you change the position of painful using the therapy, there is no effect. Choose the same position or the movement which is painful for the therapy is nothing but your level 3D symptomatic movement and position. Coming to the last part, that is your types of neurodynamic dysfunction. We have already learned in the last class that there is something called as closing manure and opening manure, where in your closing manure, the moving interface is nearing by to the neural structure. And in your opening manure, the moving interface is going far away from your neural structure. Remember that point. Also remember that the spinal column on extension is coming closer. The posterior part of the spinal column, it comes closer when you do extension to the spinal cord. So best example for closing manure in your spinal column is that nothing but your extension. When you're going to do flexion, your posterior segment of the spinal cord, which is already close to this posterior segment of the spinal column, which is already close to your spinal cord, moves away from the spinal cord. So best example for opening manure in your back is nothing but flexion of the torso. So keeping those 2 points, that is what is opening and closing in spine and what is opening and closing by definition, will look into what are the types of neurodynamic dysfunction. Coming to first one, that is only closing. Think only right now about only closing, that is your extension. So there are two types of dysfunction in closing: reduced closing and excessive closing. So 1A is reduced closing, 1B is excessive closing. Coming to 1A, closing movements provoke symptom. In reduced closing, the patient, closing is what in spine? Extension. So whenever a patient is started performing extension, it is going to produce pain. That is, there is restriction in extension movement. This is going to produce pain. That is nothing but your reduced closing. There is some restriction present in the closing manner of the spine. That is nothing but in your extension movement of the spine is causing pain. That is nothing but your first point. Already told, often restricted. Because of restriction only, person cannot move in extension. That is only causing him pain. That is nothing but your second point, often restricted. Third point, here definitely associated contralateral list is possible. Please remember this. Contralateral list is possible in reduced closing. Coming to 1B, excessive closing. That is nothing but person is excessively bending backward. So there is no great restriction because the person can excessively bend backward. It might be due to hypermobility as well. So suggests the second point. Hypermobility in closing direction is often present. So whenever a person can touch his hand backwardly bending to the floor, that is nothing but your hypermobility. So hypermobility is definitely present, and due to hypermobility, there is no restriction. So there is excessive closing. And also third point, no list is present in excessive closing. Coming to opening, what did I tell you to remember in opening for spinal segment? That is torso flexing forward or forward bending or your trunk bending forward. Please remember that. Now we'll deal with 2A, that is reduced opening. So reduced opening is what in 2A? If compared to, on comparison with the spinal movement, there is reduced flexion, there is reduced forward flexion, reduced trunk flexion. So let's look into it what it is. Reduced opening. Opening movements provoke pain. When it is reduced, so when you are bending forward, there is start of the pain. That is nothing but your opening movement provoke pain in reduced opening. So now you know that when you are bending, something is paining. That is nothing but your 2A type of dysfunction, type of neurodynamic dysfunction. Now coming to the cause. What is the cause for 2A? When you are bending forward, I'll be dealing, it is in the new Mulligan concept. Initially, at the start, it might be due to recruitment of the muscle fiber. So the pain is usually in the muscle. At the end, it might be due to again stretch of the muscle fiber. Throughout the range of motion, there is dynamic movement. So again due to muscle. But at the end, according to Mulligan's concept, it is usually ligament pain. So please remember this. Depending on the where is the pain during opening maneuver, we will be dealing that part under Mulligan concept. So for now you remember, according to neurodynamic concept, reduced opening is whenever you are going to open up a segment, for example, whenever you are going to bend your torso forward, there is initiation of pain. That is nothing but your reduced opening. Coming to second point, ipsilateral list is present. That is your same side list is present. In reduced closing, contralateral, that is opposite side list is present. In reduced opening, trauma or dysfunction in opening direction is a must. There has occurred some trauma in flexion direction to the anterior part of the vertebrae, or there must be some dysfunction of the muscle or some tear in the muscle which is not avoiding the muscle to stretch further in flexion position. This might lead to pain during flexion, hence leading to reduced opening of the spinal column. Coming to the 2A last point, neurodynamic tests are often abnormal here. As according to the neurodynamic concept given by Shatlock, neurodynamic tests are often abnormal in 2A. Coming to 2B, excessive opening. Whenever this is provoked by opening, that is nothing but excessively forward bending. As I already discussed in 1B, that is excessive closing, you need to do hypermobility. Same thing applies here, excessive opening. Either you need hypermobility or you need postural or you need repetitive movement. So this is nothing but this component should be present in excessive opening. So the last part, neurodynamic tests are often normal here, but in 2A, neurodynamic tests are often abnormal. Please remember, reduced closing and reduced opening, that is nothing but your reduced extension and reduced flexion respectively. We know that there is some pathology, it should be treated, correct? But also excessive closing and excessive opening is also a pathology. That is, it has occurred due to either postural stress, repetitive trauma, or your hypermobility. That also must be treated if it is causing hamper to the daily activity. So this was the assessment part of the neurodynamic. So this is the end of the lecture.